My name is Patrick Lowe, and my name is Patrick Lowe, and I'm a consultant neurosurgeon at the Royal Children's and Royal Melbourne Hospitals, and I'll be your convener tonight. Before we begin, Rax and I would like to acknowledge the traditional owners of country throughout Australia and recognise their continuing connection to land, waters, and community wherever we may be tonight. We pay our respects to them and their cultures and to elders past, present, and emerging. I would also like to pay my respects to elders from other communities who may be here today. Tēnā koutou katoa. Nau mai, hare mai ki tēnei hui a atata. Thank you all for logging in tonight for what will be a very interesting and very important presentation. Just over 2 years ago, if anyone would have suggested that we would be here this evening online, most would have thought that we were talking about computer gamers gathering for an internet battle. What COVID has taught us, however, is the importance of the digital world. Along with its positive, as we all now know, there are a great number of pitfalls, and unless we are across these, we will truly be left behind. This is why tonight's webinar by Dr. Kathy Rainbird is so important. Before we begin, I'd like to go through some very basic housekeeping. I don't need to tell you where the toilets are or where the coffee machine is, so I'll pass through that point. But I would like to remind all the attendees to keep their cameras and microphones off during the webinar. If you have any questions during the webinar, please use the chat function and send these through, as our staff will be here collating them, and we'll go through these at the end of each session. Any questions that go unanswered may be forwarded to college.vic@surgeons.org. The link will be found at the website. We are recording the webinar, so there is no need to jot down any information like we did in our university days. So, there will be a very short 3-question survey at the end of the webinar, so I would be grateful if you could kindly fill these in. So without further delays, I'll now call on Dr. Kathy Rainbird to start her screen. Now, Dr. Rainbird holds PhD in behavioral science in relation to medicine and is a senior provider adoption lead at the Australian Digital Health Agency. Dr. Rainbird is based in Western Australia, which is an absolutely wonderful place that unfortunately we have all missed visiting, but will once again be open very soon. Dr. Rainbird has been working with Aboriginal medical services and other healthcare providers both across WA and nationally, training them in the benefits, features, and clinical use of My Health Record. Welcome, and the platform is yours, Dr. Kathy Rainbird.
Thank you very much, Patrick. I'm just noticing that my ability to share screen's been disabled. So Lauren, if you could activate that for me, please, because I can't share my screen at the moment. Thanks very much for that kind introduction, Patrick. And as he was saying, I think the digital health tools that we've all now had to embrace, highlighted through COVID, are some of the things that I'll touch on this evening. But in particular, I'll be covering about My Health Record and also about electronic prescriptions. So I'll just try sharing my screen again. It looks like it's working now. Thank you very much, Lauren. And I'll share my slides. I'll just go to full screen. So I guess as this title screen indicates, I work for the Digital Health Agency. We are the agency that's been tasked with rolling out some of these national digital health tools. But ultimately, as this title of this evening session suggests, it really is about enhancing patient safety and improving patient outcomes. This is what all these tools are here for. They're not another thing for you to have to complete or another thing for you to have to do, but hopefully to make your lives easier and also ultimately make health outcomes better for patients. Patrick's already done the acknowledgement, but I would also like to acknowledge any traditional owners of country throughout Australia. I'm speaking to you this evening from Menang Pibilim country, part of the Noongar Nation, and I'd like to extend my respect to them and their cultures and to any elders, both past and present, as well as any Aboriginal or Torres Strait Islander people joining us today. I've already described what I'm going to talk about while we're waiting for the screen to come up. First of all, I'll go over my health record. I'll give you a bit of an overview and talk about some current statistics and highlight the key information that's available through my health record and how that might, as I said, support better clinical outcomes for your patients. I'll talk about how to get connected for those of you who aren't yet using it and point you towards some useful resources. At that stage, I'll take a little break. So if you do have questions, as Patrick said, please feel free to type them into the chat pane, and I'll take a pause there for any My Health Record specific questions. And then we'll go on to talk briefly about electronic prescriptions, give you a bit of an overview about how that's working and how it can fit into current workflows, again, pointing towards some useful resources, and stopping then to take questions and answers from all of you. So as preempted by Patrick's introduction, and as I mentioned before, the Digital Health Agency has really been tasked with delivering these digital health tools to help improve the healthcare system and health in general for all Australians. And some of the key things in particular that have been accelerated during COVID-19 have included the use of things like telehealth, which is fantastic, especially for those of us who live in regional or remote parts of the country, as well as secure messaging, My Health Record, and electronic prescribing. And so these digital health tools are things that are being delivered across a national level to help support better outcomes. So I'm sure most of you have heard of My Health Record, but there's a few things to point out about it. In particular, it's really there to ensure that health information is available whenever and wherever it is needed. It doesn't replace your existing clinical information system or medical records, but rather provides a complementary source of information. So it's a secure online repository for key health information that's then available to any healthcare professional who's involved in that patient's care. It is personally controlled in that the individual patient gets to firstly choose whether or not they have a My Health Record. The good news is that most people do have one, and those that originally opted out have since been slowly opting back in, so the numbers are going up, which is great. But they can also choose to put, say, a PIN code over their My Health Record and only provide access to those healthcare professionals who they give that code to. Likewise, they can also ask that you don't contribute specific information. So if they have something particularly sensitive that they don't want shared through their My Health Record, then they can request that that isn't uploaded into the system and it's kept private. It is part of a national system, and the beauty of that, of course, is that it helps cross some of the silos and fragmentation that exist across our healthcare system. So it crosses the public and private divide, as well as state boundaries. And it means that you can access information that may have previously been held primarily in primary health sectors, such as pharmacies or GPs, as well as other parts of the system, such as pathology reports and hospital discharge summaries and so on. The beauty of it is that it is accessible at all times. So if you are suddenly seeing a patient who has come into, say, a hospital and you need to provide some emergency surgery, the GP's closed, you can look at their My Health Record and hopefully find some useful information, background medical history, background clinical conditions, previous hospital encounters, pathology reports, and so on, 24/7. And there are significant protections in place that underpin the My Health Record system. In particular, there is specific legislation that underpins the use of the system. Primarily, it's there for the purpose of providing healthcare. And as long as you're using it for that purpose and using it in an appropriate way, then you're fine. But you do need to make sure you're using it in that way for the purposes of providing healthcare to that person. Other protections in place include that all of the software that connects and is enabled to interact with My Health Record has to go through special technical conformance requirements. So meeting those requirements is part of their process as a software vendor, and then they have to have a digital security encryption certificate that works in the background to ensure that any transmission between the two systems is secure as well. So some software doesn't yet talk to my health record, and some is coming along that journey. And I'll give you a bit of an update about that further on in the presentation. In terms of current connections and use, the agency has been working across state jurisdictions, across primary health networks, and encouraging uptake in particular for GPs and pharmacists initially, as well as public hospitals and private hospitals. And you can see here that we've actually done really well in those sectors in terms of the number of registered organisations in that space, as well as the increasing amount of use for the system. And I think COVID has also helped push that along, in particular vaccination information being readily available through my health record. Of course, having public hospitals connected is great because it means those discharge summaries are available as well. And interestingly, the viewing rate in the public hospitals has started to really ramp up. You can see here that the viewing has increased significantly over the past 6 months. And healthcare providers in the hospitals are now looking for documents in my health record regularly. I should point out that while this has been the focus initially, that specialists and surgeons are now a group that we're focused on prioritising to get connected as well. So you're the key priority group for the agency at the moment, along with aged care. In terms of what's inside, these are statistics from December last year, so a little bit dated now, but you can see here that there are already over 537 million documents uploaded into the system. So at first, when people had a My Health record, they started out almost like an empty online folder, and it was only as they interacted with the healthcare system that information was uploaded and contributed into it. But we now have all of those different connections happening, and some of those documents are defaulting to send. Some require an active upload, perhaps via the GP, but a lot of them are a default to send, automatic upload. And so the number of clinical documents, as you can see on this slide, is now over 213 million documents. There's also medicine-related information, and the individual themselves can contribute information. You can see that some have taken up that opportunity. So this slide is to give you an overview of all of the different types of documents that are currently available through My Health record. And on the right-hand side is the list of documents that can be uploaded by healthcare professionals or providers, or provider organisations such as hospitals. So the top one on the list is the shared health summary, and that's the one that's generally uploaded by the person's main regular healthcare provider. So that would perhaps be their GP usually. Could be a registered nurse or an Aboriginal health practitioner. And that shared health summary can be really useful if you are seeing someone who you haven't seen before and you haven't got a lot of background information. If they have a shared health summary, that can include some really useful key information such as allergies, adverse reactions, medicines, and past medical history. So if you find one of those in someone's record, I suggest having a look at that. I won't go through that full list on the right-hand side, but it's just to give you a taste of what's there. If you have any questions about any of those, please pop them in the chat pane. On the left, you can see the list of information that consumers or patients can enter themselves, including some information in the form of a personal health summary. So if they have a significant allergy, they can add information about that themselves, as well as any individual medicines or over-the-counter medications they might want to add. They can also add a copy of advanced care plans if they have an advanced care plan. We've been working with Palliative Care Australia to encourage people to do that. So really useful if you are looking after someone who might have those end-of-life decisions being made. Medicare information also comes through into My Health record from Services Australia, and that can be quite handy. It includes things like latest PBS and MBS claims item numbers. So if you're providing a service where there's a cap on that number of claims that someone can make, looking at how many times or when they last had that claim made can be found through My Health record. You can also find organ donor register status and the Australian Immunisation Register, which of course has become particularly significant. In the circle around the middle, you can see that there's a number of other documents in those round symbols, which indicate documents that are actually generated by the system as you open a person's My Health record. So for instance, the medicines information view that's listed there at the top is designed to make it quick and easy for you to find any medicines information that's held across that person's My Health record. So you can imagine that quite a number of those documents listed around the outside, it could include medicines information. That medicines overview screen brings it all together on one single page so you can quickly find it and get to those source documents if you need to. Likewise, there's an overview document for immunisations, which includes information from the immunisation register, but also any other listings of immunisations elsewhere from across the person's My Health record, as well as a pathology and diagnostic imaging report overview, so you can quickly get to the relevant reports that you are interested in seeing. If you weren't the original requester, you can possibly find them in the person's My Health record. That being said, I should point out that for those pathology and diagnostic imaging reports to be uploaded, the path lab or the imaging service needs to have also registered and be enabled to connect through their software and provide those reports. So not all of them are yet. There is an extensive list available on our website, which is digitalhealth.gov.au. And so if you have a particular service and you're wondering why it's not in there, you can check that list. But we are working with lots and lots of those labs at the moment, particularly around pathology reporting and getting COVID-19 results into My Health record. There's been a great amount of work happening in that space recently, of course, and we're trying to get more and more of those services, path labs, connected. So keep watching this space. So I've just got some screenshots here to give you an idea. This is all fictitious data, so don't look too much at the detail, but it's just to give you an idea of what some of the documents look like. And it all varies in terms of how you access it through your software system. It all varies which buttons you press. We are running virtual classroom sessions where you can learn how to find this information through your specific software if you're not sure. I'll point you to those. But otherwise, this is just to give you an idea of the standard look and feel of these documents. So as I mentioned, this is a typical document that is uploaded typically by the person's GP. It's called a shared health summary and it has these clear headings so you can quickly get an overview of that person's adverse reactions, medications, medical history, and immunisations that they've had at that specific practice. So if they've been going to their GP, the same GP for some time, that medical history could be quite extensive and quite useful for you to refer to. This is an example screenshot of that medicines overview document that I mentioned. That's one that's generated by the system and brings all of the information from all of these different source documents and displays them on this one screen. Across the top here is a navigation panel, and the first section that always appears is the allergies and adverse reactions. Then there's a click to get to the medicines preview, a direct click to the most recent shared health summary, and also a direct link to the person's discharge summary if they have had a hospital admission that's had that uploaded. So it really is a really useful go-to source. This in particular, this medicines view, some clinicians say is their go-to document within My Health record to get a quick snapshot of this key information for their patients. And then when you click on those tabs underneath is the details. So you can see here we've got the medicine and the dosage and the source documents listed. This is just another screenshot example of that medicines view with the allergies section highlighted. So you can see there that there's some information that's been entered by the patient themselves, as well as something that's been uploaded in the form of an event summary. That's again just an example. The discharge summaries, sometimes they're listed and presented in this way. Sometimes there actually is a hyperlink to a PDF of that discharge summary. So it depends how the hospital's got their connection working. If you see a blue hyperlink, it generally means there's something you can click on to get further into the document if you can't see the full document on your screen straight away. This is an example of that pathology report overview screen, and basically you can look down this list and find the report that you want to. When you see it, you want the full blood count, for instance, then you can just click on that blue hyperlink and you can open up and see it straight away. And this is that immunisation overview. So the first, again, there's a navigation tabs along the top. The first section that always opens is the Australian Immunisation Register listing, and they're listed underneath. So we can see this is, again, a fictitious example, but we've got our pretend patient here who's had their 2 doses for initial COVID-19. So if they hadn't had their booster yet, you'd want to be checking whether they'd had that or not. This is an old screenshot, by the way. We have updated to reflect the need to have boosters included as well. So the key message for you as clinicians is that My Health Record gives you quick and easy access to key health information that you may not have directly received. It can mean less time gathering information, less burden for you and or if you have a practice manager or other staff who support you, less time for them spent trying to find that information. And also if you are contributing information back into the person's My Health Record, which could be done in the form of an event summary or by uploading a copy of your specialist letter, that will then also potentially mean that other healthcare providers don't have to recontact your practice and request a copy of that. You do still need to send it to the original referrer in the usual way that you do that, whether it's secure messaging or, dare I use the word, fax. But it means that if that patient goes and sees another specialist or sees some other clinicians, they won't have to recontact your practice. They can potentially find that copy of that letter straight through their My Health Record. And of course, as I said at the beginning, it's all about improving clinical decisions making, making better care for patients by having access to that patient-specific information whenever and wherever it's needed. And of course, the big benefit is as well avoiding any duplication of previous tests that have been done and the impact that can have as well in terms of patient safety, as well as speeding up time for you in your practice. So in terms of how to get connected and start using My Health Record, if you aren't already doing so, there are a couple of ways that My Health Record works. For the individual as a patient, they can log into their own My Health Record and view it through the MyGov link. There's a My Health Record link under the MyGov portal or through authorised apps. If they want to contribute information, they have to go in through that MyGov link. For you as healthcare providers, you can view either through your local hospital applications or through the conformance software, so software that's met those technical requirements I mentioned before. Or there's a third option. If you don't have either of those, you can use what's called the National Provider Portal, and that gives you the ability to view someone's information. That portal is a view-only system, so you can't upload that way, but you can at least see it. Uploading through hospitals is generally done in the back end through your technical teams. They'll have set up sending up hospital discharge summaries and potentially specialist letters. For you, if you're in private practice, if you have software that is integrated with My Health Record, then that will allow you to upload as well. As I mentioned, the agency has been working closely with the software vendors and recently had a specialist software vendor industry offer to encourage them to integrate with My Health Record in a way that made it more user-friendly for you. And their software is really starting to come to fruition. As you can see by this link, this list, there's quite a few that are already in release and quite a number that are coming along for the ride as well. There are other software systems that also enable integration with My Health Record, but these ones have specifically taken that next step in terms of making it more integrated with uploading of specialist letters and other features relevant specifically to specialists. So I guess the key message for you is if you are using a clinical software system in private practice, is check with your software vendor and find out if they are integrated with My Health Record and what functions they have enabled in their systems. Those ones that have gone through that specialist industry offer allow for access and viewing of all the documents that I've just shown you, as well as those overview documents, an easy upload of your specialist letters without interrupting your normal workflow, as well as potentially uploading of your prescriptions that you write, Also enabling authorised practice staff, if you aren't actually viewing the person's My Health record but have support staff that provide that support, they will be able to be authorised to view that information. Sorry, I've got dogs barking in the background. And also practice staff can upload your specialist letters once they have been approved as well, as long as they're authorised within your practice to do so. In terms of the things that you need to do if you are in private practice and want to get connected, this is a bit of an overview of the process. One of the things you need to make sure you have is a policy in place that covers how the system is used. There are templates to support that available through the website that can be adapted for every business or practice. There is a process to get registered and connected, but we do have a registration connections team that can support you in that space, as well as your software vendor probably having information available. You need to make sure staff are trained if they're using the system and understand their obligations and requirements and when they're allowed to use the system, and also make sure those people have been authorised within your software. We are running specific sessions for practice managers and support staff as well around all of the sort of background obligations and the process of getting set up if you have anyone who's able to attend those sort of sessions for you. In terms of getting registered, I mentioned we have a connections team. That's their email address on screen, as well as the phone number. If you do call that line and ask for the Specialist Connections support team, they will guide you through that whole process of getting registered. We're also working closely with your local primary health networks. They have been mainly working in the primary health space, but they are available to support specialists as well. So you can reach out to them, and we have a locator map hyperlinked there, so you can find out which is your local PHN. And if you're working in a hospital, the best thing to do is check with your clinical informations manager or quality manager, health information manager, and find out whether you're connected and how you can access. Generally, it's already set up and there's just a little icon in the patient's record, and you can go straight in and start using. Often there'll be information on the local health district's intranet pages as well about that. So if you have hospital questions, probably direct them there as the first port of call. Couple of useful resources. In particular, I mentioned those virtual classroom sessions where you can see how you can use My Health Record through a whole different range of clinical software, whichever one you use. We have quite a few. We have demo versions. We're running sessions specifically also for hospital staff, which demonstrate some of the key middleware that a lot of the hospitals use. And as I mentioned, those sessions specific for practice managers. So I might take a pause there. Patrick, how are we going for time and how are we going for questions?
Yeah, we've got some questions. Fantastic questions. So, no, thanks for that so far. Surgeons, we're often very early in adopting things and sometimes very late in adopting things. So it's a great summary to sort of ease our mind, ease our concerns. So I might just go straight to the questions, if I may. I've got two questions from Stuart Proper. Firstly, he mentioned that the usefulness of information in the electronic record is dependent on the accuracy. So how can misdiagnoses and incorrect information on the My Health record be corrected? Is there any way to correct those?
Yes, that's a very good question. You're absolutely right. And part of the sort of requirement in using the system when you do implement that policy is that when you are uploading and contributing information, that you're ensuring whatever you're contributing is accurate and up to date and complete at that time. But you do need to keep in mind that there could be misinformation. And if you do find something that is inaccurate, then if you were responsible for uploading it, you can also then remove it. So if you have it built into your software, there's usually a way that you can take that document back down, or it can be superseded. If you find misinformation from some other healthcare provider, you won't be able to remove it from their My Health record yourself, but encourage the patient to contact our 1-800 number and ask for that information to be removed. Patients can actually also go onto their own My Health record if they're computer savvy enough and hide documents. So if there was something like that, they could make sure at least that it was hidden from other people being able to see that misinformation. But often we're looking after people perhaps who aren't as computer literate. And so that 1-800 number is probably the best option. If it's a clinical safety issue, you can also report it via that number, which I'll pop up at the end of the show.
So is the onus also on the patient to change it, or on the individual who put it up?
It's primarily on the individual who put it up, but the patient may have moved on from that clinician and they might only find out when they see another doctor that there's something that's wrong. So they might not have another appointment to go back and see that original clinician. So there's a couple of avenues there. So the onus is, if they were the author of the document, generally they're the one who should be removing it. But if it's something clinically dangerous and the patient isn't going back to them, then definitely call that 1-800 number and report it.
Okay. Now, Stuart's got a second question. Is there a mechanism by which images and videos can be uploaded?
That's another good question. Unfortunately, at the moment, in terms of those diagnostic reports, it is just the reports, not the images. I know that some radiology services are embedding a little thumbnail, but it's all to do with digital space and the amount of time it would take to download that information and clog up the system. So at the moment, it's just those reports at the moment, but there's work being done to progress that down the track as well.
It's almost like the law courts, because they never show the images, they just show someone's report. So it's similar to that.
Fuzzed out, yeah.
Okay, got another question from David Mitchell. Are radiology companies obliged to send results to the MHR, or can they choose not to? What proportion of radiology reports are on the MHR?
Yeah, so it is up to the individual radiology service, firstly, whether they get connected to talk to My Health record in the first place. So they get to call that shot themselves. That's at the discretion of their business owners. In terms of the obligation, once they do make that decision to connect, in terms of uploading, they are generally defaulting to upload everything unless directed otherwise. And that's usually done by whoever is the requester on the request form. There's a checkbox that can be indicate to say, do not send to My Health record. So that request can be made by the requester or by the patient themselves. So if the patient says, say to you, Patrick, I don't want you to have this report put into My Health record, can you make sure it's not going to go in there? You can say, yep, sure, check the box, do not send. And if the radiology report, service receives that request in that form, they'll make sure it doesn't go. It has to be built into their mechanisms.
Okay. Now, I've got one last question before we move to the next part of your talk from Greg Self. Do docs for specialists upload require patient consent?
Basically, in a nutshell, no. Under the legislation, you, as long as you're providing healthcare to that person, you have the authority both to view their record and to upload to their record without explicitly having to seek consent every time. So under that legislation, you have authority to view and upload. Of course, it's up to you in your personal practice whether you'd like to mention that you're going to potentially upload to the record and confirm that they're happy to have that happen. That can just be done as a verbal thing, that's fine. But under the legislation, you're covered.
Okay, thank you for those answers, Kathy. We'll move on to your next talk.
Lovely. So the next digital health tool that we're talking about tonight is electronic prescriptions. This is just a bit of a sort of a evolution of electronic prescriptions, or prescriptions if you like. So over on the left of the screen, you can see the original handwritten script on the paper pad. Moving on, still a paper prescription, but this time with printed information, which for those of you who have handwriting like mine, I'm sure it's well appreciated when people transferred over to using printed onto paper scripts. That, of course, is still a paper prescription, still requires the signature of the prescriber and so on. The next one on the screen, again, it's still a paper script, but you can see down the bottom it has a little barcode. That barcode enables some key information to be scanned by the pharmacy and transmitted via a transcription exchange service. And that includes things like the identifiers behind that patient's information. Still a paper script. The final image, which is of the little SMS token, is the electronic scripts. In fact, that's not actually the electronic script. It is just the token or the QR code that unlocks the prescription. The prescription is actually stored electronically in what's called the prescription delivery service. So it's sent from the prescriber into that repository prescription delivery service, PDS. And when the patient presents that token for scanning, that then unlocks that prescription and the pharmacy can download it and open the actual electronic form. So basically, electronic prescriptions are an alternative to paper scripts. So previously, it was only a paper script that had been signed, which was a legal form and which could be allowed to supply medicines. Now, both of those forms have been passed through legislation at both Commonwealth, state and territory levels. So electronic prescriptions are a choice. They're not mandatory. It's up to you whether you want to use them. Patients might like them or prefer them. And of course, while we're in the age of telehealth, they are extremely useful because you don't have to be face-to-face with the person. So if you're having a follow-up consult with someone and need to give them some medications, if you can do the follow-up by telehealth, you can just send them that electronic prescription wherever they are in the country, and they'll be able to receive it on their phone. So patients and prescribers are able to choose either the paper or electronic form, but not both, because that would mean the potential for having the same script filled twice. So it's one or the other, not both. They can have a paper script for one thing and an electronic script for something else. That's fine, but not the same script. These are just some overview stats about what's happened with electronic prescribing. And this was really fast-tracked because of COVID-19 by the agency. When we started out at the beginning of 2019, no one would have predicted that this was going to happen and that there would be this huge push towards electronic prescriptions. But you can see in that top left-hand box, we've had over 39 million electronic scripts created, either as original or pharmacy repeat scripts. So that's massive change in a short amount of time and really pushed along through because of COVID. It was already on our plans, on the radar to happen, but this just really fast-tracked it along. There's a whole lot of other stats on this slide. One thing to point out is what's called the active script list, which I'll talk about a bit further on in the presentation. You can see that's trending up. Basically, it gives patients a way of having all of their scripts available on a single list that the pharmacy can access, so they don't have to keep track of all of those SMS tokens. I won't go through all of those stats today, but they will be provided in the slides if you're interested after the session. The good news is that electronic prescriptions can be used for pretty much anything that you write a prescription for. So all of the PBS medicines, authority scripts, Regulation 49 private scripts, and even Schedule 8 medicines. In terms of how it works, you, the doctor, prescribes the medicine via your software or through the hospital applications. You would then send a message to the patient during that consultation. Again, if it's by telehealth, you can send it while you're sitting online with them. And the patient receives that QR code or token on their phone. They can receive it in a couple of other ways, which I'll show you in a second. But getting it via SMS, of course, is easy and convenient, and most people have a phone that has that enabled at the moment. The patient can then either send it to the pharmacy, they could send it by email or find out their local preferred pharmacy's mobile phone number, or they can take it in if they are not isolating and present it in person to have that script dispensed. There are a range of different apps and applications and ways that these tokens can be managed. A lot of pharmacies have their own specialised medicines apps for keeping track of prescriptions. And most of the pharmacies have the scanning devices already set up in their pharmacies to be able to receive those tokens when a patient presents them. So there is also, if for some reason the patient doesn't want to have it via SMS, then you can email it to the patient if they prefer that method, and some people do prefer to get it via email, or it can even be printed on a piece of paper, the token, so that the person can then take that bit of paper to the pharmacy if they wish. Which seems a bit counterintuitive, but for some reason some people might like it that way. At the pharmacy script in counter, that token is then received and scanned, and they're able to then dispense the medicine as per usual. And it's the pharmacy then sends repeat scripts back to the patient as a new token. As I mentioned, there's a range of ways that those tokens can be managed. So the patient can receive them on their mobile device or as an email. They can also have a validated carer or agent who receives those tokens as SMS or email on behalf of them and can take it to the pharmacy for them. They can use those mobile apps to store tokens, or they can use the active script list. So the active script list, as I mentioned, is a solution that the agency's been rolling out, again in collaboration with the pharmacy dispensing software developers. And it means it has a list of all active prescriptions and repeats that can be dispensed, and it saves the need of patients having to keep track of their tokens on their phone. So the dispensers can access that full list and follow after they've got proof of that patient's identity. They can get them the scripts filled then and there. So electronic prescriptions particularly have become important in this time of telehealth consultations, but they also give provide patients with greater choice in terms of maintaining their privacy, but also having that information available where it's needed and being able to isolate if needed. Removes the need for handling and storing of physical paper scripts, improves efficiency at both the prescribing and dispensing end, and hopefully reduce dispensing and prescribing errors along the way. I've already talked about the support for digital health and telehealth as a result. We do have a range of resources. If you're interested in finding out more about electronic prescriptions, there is a free online training module if you want to complete that. There's also lots of fact sheets and information available through our web pages. There are upcoming webinars and podcasts also available. The Department of Health also has a range of specific resources around electronic prescribing, including some of the policy fact sheets and frameworks behind the system. That was short and snappy, but that's electronic prescriptions in a nutshell. Patrick, do we have any further questions?
No, I don't see any new questions, but can I just ask a separate question? Do you have any data on the uptake of MHR and e-prescription state by state? You know, during the COVID, we got used to looking at almost like the leaderboards, you know, for each state. Is there a particular state that is more into the electronic health records than others that you might know of?
I could tell you, but then I might get in trouble.
Okay, so we'll leave that alone.
No, basically, there are the stats there, but each jurisdiction likes to keep that information a bit close, if you get what I mean.
Yes.
But
that's good. No, I got saved by the bell. We got saved by the bell. There was a question.
I like to brag and say that WA is leading the way in some of the uptake and use of my health record. They've actually really embraced quite a few of the different programs and projects, but I think each state has its own differences.
We'll leave it as that. We'll leave it as that. We have got a question from Christopher Love. How can we pressure software providers to implement e-prescriptions? That's also
contact them.
political too.
Contact them. That's your job. No, it's not your job, but it does help if you as clinicians talk to them about it. It is more likely to have an impact and encourage them to do it than from the agency coming along and saying, we think you should do this. If you are keen to see this happening, then if you talk to your software providers, they're more likely to make that change.
Okay. Do we have any more questions from the floor at all? Okay, so you work with a lot of the Aboriginal and rural communities. What's the uptake in the regional and First Nation people like with electronic records?
Yeah, that's a good question. To be totally honest, I haven't looked at the recent stats around Aboriginal and First Nations uptake. But in terms of my work, a lot of my role before COVID was actually going out and visiting the Aboriginal medical services and training the staff and talking to them about concerns that the community members might have. A lot of concerns around that privacy and security side of it and who can see it. We've done a lot of work with the state Aboriginal health community controlled affiliates. And so they have actually been working hard to get that messaging out. There's some great little resource sort of storybooks for community members to explain it in clear language around who can see what and how it works for them. And yeah, I've just actually been reviewing some really nice modules that are about to be released specifically for those staff working in those Aboriginal medical services, which says, oh, well, how do we talk to everybody about this and how do we explain it to them? And they're going to be a really great resource.
I really like your data to say 137,000 who had opted out before is now back on. So that's,
yes,
it's a really
it's really encouraging, isn't it?
Very encouraging.
Yep.
So we have some more questions. Stuart Parkinson asks, will the ability to prescribe electronically be possible in the future without utilizing software providers?
Generally,
cut out the middleman.
To generate an electronic prescription, you would have to be using some sort of digital form for it to be able to become a digital script or an electronic script. So it may be that if you're thinking about doing it in a hospital, it may be that hospitals will build the applications within their prescribing system. So you won't necessarily need to have a separate software but if you're in private practice, to actually generate an electronic prescription, you'll have to have some sort of electronic device, electronic system to actually create it in the first place.
Unless the government decides to become a software provider unilaterally.
Which I don't think it's going to happen.
It's not going to happen.
I don't think that's going to happen.
Okay, so Stuart Cropper, another question. Which state and or federal legal changes, what state and or federal legal changes have been made to facilitate the EHCR? How often will these laws be reviewed?
So if that's the legislation specific for my health record, yes, EHCR, people use different acronyms for different things. So I'm just making sure I'm addressing the right one. So the original My Health Record Act was formulated and released. It's a 2012 Act, and that is still in place. There were some amendments to that Act prior to the change to it being an opt-out system. So when we went through that process of saying, hey, everyone's going to get one unless you say you don't want one, then there were some further changes made to that legislation. All of those links to that legislation are available through the My Health Record website, which is on this slide here. You can find, if you search for legislation, you'll get the full list. But basically, they're pretty well set now, I think, in terms of how they're working. Occasionally, we have to tweak things. For instance, we had that rule around we have a 7-day delay for pathology results being visible to the patient. They're immediately, once they're uploaded, they're immediately available to the healthcare providers who have access to the system. But there was a 7-day delay on patients seeing those to give the clinician who requested a chance to review the results before the patient reads it themselves. For COVID-19, we realised that that needed to be changed. They need to see that result as soon as possible. So there was a change to that rule made so those COVID-19 results could be immediately seen. So, you know, things like that are happening as required, I guess, and pushed along as quickly as possible when needed. But generally, I think the main legislation and the main act is pretty well set and unlikely to change significantly further.
Okay, so I'll leave it open for a few more questions. Okay.
I was just going to point out that's that 1-800 number. If you do find any clinical documentation that you feel is a safety risk, that 1-800 number at the top of the screen is probably a good one to call as a starting point.
The whole webinar is recorded, so you can look back on it and check all the resources and the phone numbers. I've got another question from Stuart Parkinson. Why isn't the Commonwealth Health Department wanting to take responsibility for electronic prescribing and taking responsibility away from private software providers?
I don't know if I can answer that question. I don't know the answer. I'm not from the Department of Health as such.
Yeah. I think we'll have to ask maybe another webinar from the Department of Health to answer that particular question.
Yeah, exactly.
It's quite difficult. Greg Self asks, can the MHR Access become mobile friendly or become an app?
Oh, I have good news in that space. Good question. Thank you for asking that one. So there is about not far on the horizon, there is going to be an app specifically for individuals, so patients, to look at their own My Health record. There'll be an app on their phone. And there is work being done on a mobile solution for clinicians who work in hospitals. So a lot of the state jurisdictions connect to My Health record through a middleware that's called or known as HIPS. And there is a HIPS mobile solution available now. So if your hospital uses that middleware, have a chat with your clinical information managers and find out whether they can give you access to that HIPS mobile. It's not an app that you find on the App Store. You can't just download it that way. They have to sort of switch it on at their end at the hospital. But then you would be able to see My Health record for any of those hospital-based patients wherever you are in the hospital on your device, in your hand.
No, that's a great question from Greg.
Everything's exciting development with it coming.
So it is not far away, Kathy.
It's available now.
Oh,
that HIPS mobile solution, depending, as long as your hospital has got the up-to-date version of HIPS and they can switch it on for you, then yeah, you can get that now.
Right. Okay, so I think we've come to the end of our webinar. Remember, any questions that you have, please send it through to the email address that's on the website. And just for your record, it is college.vic@surgeons.org. I'd like to thank Kathy Rainbird for a fantastic talk, very informative. You know, opened my eyes a lot. Also, I'd like to thank the hardest workers of this webinar, which is Lauren and Kathy from RACS. Without their expertise and dedication, none of these webinars, which we now take for granted, would ever get off the ground. So thank you to all involved. Thank you for the attendees for joining us. And just please don't forget to complete that short survey when this closes. And once again, Dr. Rainbird, thank you very much for your time.
Thank you very much. Good night.
Yeah, have a good evening, everyone.